Chairman, I yield.
Thank you. The gentleman yields back. The chair recognizes the chair of the full committee, Chair Rogers, for 5 minutes for questions.
Thank you, Mr. Chairman. I too want to just say thank you to all of our witnesses for being here and your patience as we're dealing with an unpredictable schedule. This has been a very important hearing, one that we've wanted to have for some time. And as you've heard, the theme of the healthcare discussions have been about the need to address healthcare consolidation. We're hearing from patients, employers, policy experts about how consolidation in so many cases it's increasing the prices without necessarily improving quality of care. This is directly relevant to the conversation we're having today. We want to ensure that the healthcare economy can sustain private practice. So I know you've answered a lot of questions, but I just wanted to go back, Dr. Pat, start with, can you talk about the difficulties of maintaining a private practice in today's environment?
Thank you for your question. I think that for private physician-owned practices, in the setting of declining reimbursement, it's very difficult to maintain competitive salaries for staff to staff your clinic and stay open. And the natural consequence of not being able to staff appropriately and having declining reimbursement is that if there's an option to consolidate your practice with the hospital, that can be an attractive option for private practices because it's difficult to be financially viable independently. So I think it's a real challenge, and I think that many of the issues addressed in this committee hearing today can help site neutrality, making physician reimbursement appropriate, that would help that challenge.
Thank you. Mr. Albanese, would you speak to reforms that you believe would reduce incentives to consolidate?
Certainly. So I can expand a little bit on site-neutral payments, which are a major driver of consolidation because hospitals have an incentive then to acquire independent physician offices, rebrand them as off-campus outpatient departments, and charge a higher rate for the same services that could be performed in a normal physician office. So I think targeting those same service areas that I mentioned before, as well as perhaps removing exemptions to the Bipartisan Budget Act of 2015, which set site-neutral rates for off-campus departments, but exempted those that were already in operation, would be another step towards that goal that was originally envisioned in that statute. And by doing so, it would help to remove this relative disadvantage to physicians who have, as has been noted, seen fewer pay increases over the years compared to hospital outpatient departments, which is one of the biggest, if not the biggest, growth in spending in Part B.
Thank you. As a follow-up, could those reforms be used to help accomplish the goal of making Medicare more sustainable for independent physicians?
Yes, the Committee for a Responsible Federal Budget estimated that pursuing these types of site-neutral reforms across ambulatory settings would save about $280 billion over 10 years and would save patients over $140 billion in their own out-of-pocket costs as well.
I'd like to also ask you, Mr. Albanese, to discuss issues surrounding cost in the Medicare program and if we're achieving our goals related to value. Could you share if you think APMs have improved the value of care in Medicare?
Well, I think by CMMI's own admission, and it has been reinforced by a recent report by CBO, alternative payment models have not been meeting the promise and the optimism that has come with them. Over the first 10 years of CMMI's operation, CBO had expected about $3 billion in savings, in net Medicare savings, whereas in reality, over that time, it actually cost the Medicare program more than $5 billion. It estimated in the second decade of operation from 2021 to 2030 that these savings numbers would be almost $80 billion, but instead it's going to be net costs of $1 billion. So I think that's a pretty clear record that very few of the models have actually saved money as statutorily required. They're required to save money or to improve the quality of care. And on these fronts, it has been a disappointment.
So are there alternatives to APMs?
I think that in Medicare Advantage right now, you see a structure that is very similar to APMs and in value-based care because they receive population-based payments. They're required to pass along the savings that they achieve through bidding to their beneficiaries and their enrollees in terms of more benefits or lower cost sharing. So these align with many of the same goals as APMs. The difference is that they've actually proven to deliver core Medicare benefits at 83% of the cost of traditional Medicare, and they have grown in popularity, with more than half of Medicare beneficiaries now choosing to enroll in an MA plan.
Okay, very good. Thank you. Thank you, everyone, for being here. I yield back.
Thank you. The chair yields back. The chair now recognizes Chair Harshberger, Ms. Harshberger from Tennessee,
I like it.
for 5 minutes for questions.
Okay. Thank you, Mr. Chairman. Thank you all for being here. Dr. Furr, I'll start with you. You know, my background is a community pharmacist for over 36 years, but I've done sterile, non-sterile home health hospice, and all these things fit right into the model that I've done my whole life. And I guess my question to you, sir, is do you think that the differential payment gap between the hospital inpatient prospective payment system and the physician fee schedules driven physicians out of business and empowered the health system consolidation?
There's no doubt that's a large part of that, along with all the hassles that the physicians have to do in their practice. So the encouragement is to move in that direction, and particularly as our physician population is getting older and the hassles are getting greater and greater, it's just easier to sell out, you know, and not have to deal with the hassles of employees, training your personnel, and even losing money on your business. You can't run a business and then know every every year you're going to lose 3 to 4%. I think we also tend to forget we're already always losing 2% for sequestration. That was the biggest thing y'all did for us during COVID. We got that 2% back. And for our primary care practice, that makes a huge, huge difference.
Huge difference.
When you're talking about 3 to 4%, it's massive.
Yeah. Well, it's like this. You have to have that person, dedicated person, doing your prior approvals or trying to figure out which generics on a pharmacy benefit manager's formulary. I understand. Believe me, I do that in the pharmacy industry too. Dr. Pat, thank you for being here today because you all have been big advocates on this bill. You know, the bipartisan legislation, the Seniors Access to Critical Medications Act. Who thought you would have to create legislation in order for a patient who is critically ill in most cases to be able to come pick their medicine up, get a family member to pick it up, or us to mail it? It's nuts. But what this legislation does, it modernizes the Stark Law to make permanent that waiver exception issued by CMS that allowed for them to do that. You know, if you look at it, you could give me story after story, I'm sure, where a patient has missed a dose or they were reluctant to even do the chemo initially, and then when they found out you couldn't mail it to them, they just didn't get it. And then what are the outcomes on that? The outcomes can be detrimental.
Absolutely. So we spoke earlier about the burden to rural Americans receiving cancer therapy, but what we didn't speak about is all of the disabled Americans or, you know, Americans that are ill because of their cancer therapy, and they are not able really to come in and get it, and they can't have a family member come in, and it makes it so much better for them if you can mail it to them. It allows them to really access care. So it ends up being an access to care issue that disproportionately burdens sick patients, disabled patients, and rural patients. So, you know, again, thank you for your leadership. This would be a monumental improvement to cancer care in America if we're able to successfully pass this legislation.
Yeah, and you know, if you look, we're just talking about part of the equation. If you look at what some of the PBMs are doing, when you have short-term changes in therapy, you know, and they do a mail order of 3 months, what's that costing? What's the waste? You know, we need to do a study on that, sir.
I encounter that every day in my practice, I'll say, as a breast cancer specialist. So I frequently will start patients on endocrine blockade in addition to something called a CDK4/6 inhibitor. It's a pill to control cancer, and it really improves their progression-free survival, but it has a lot of toxicities. I dose reduce that drug about half the time. And so when they come back, I don't want them to have had a refill because that is a multi-$1,000 loss.
Multi-$1,000 waste.
Yes. And it happens half the time if they're filled with a PBM. But if it's filled in our office and I'm able to check in with the patient before they get the refill, I'm able to manage their dose in a timely fashion. And that happens every day, you know, in clinic. That's why we see patients. Every day I'm in clinic, I make a dose adjustment. And so, you know, based on laboratory values or patient symptoms, And if they're getting it mailed to them from the PBM automatically without the doctor being involved, they don't have that tight control, and it leads to medical waste that's really poorly characterized. But we have so many stories of that well documented.
Maybe you need to make sure you continue to get those stories, because maybe that's something they need to look at. What is the amount of money that is wasted? It's easy to fix, isn't it? That's why they call it the art of practicing medicine.
Okay.
You are adjusting as you go, and I've only got 5 seconds left. I've got a lot more on the infusion side too, but it's my pleasure to introduce that bill, and I've got another co-signer in Dr. Joyce, so thank you. I yield back, sir.
I told Dr. Meeks she was next, but that's not my friend from California came back. So Ms. Bettergon from California is recognized for 5 minutes.
Thank you, Mr. Chairman. We've heard today that physician reimbursement under Medicare is not keeping pace with the increasing cost of providing care. And this gap is expected to keep growing under current law. Dr. Furr, how does the gap impact accessibility to quality care, especially for traditionally underserved communities and communities of color?
Well, 44% of my practice is African American, and many of the others are low income. Their ability to go elsewhere for care is very limited. So when those costs for us go up, it's harder to provide the care. When we have the increased administrative burden, we have less time to take care of our patients. And that's why you see a lot of physicians dropping out of practice. Their joy comes from taking care of patients and not clicking boxes. So it's harder for us to take care of those patients. We need extra staff to do the administrative stuff, which we really need them to be taking care of patients rather than doing the administrative burden.
Well, thank you. What did you say your percentage was of African American?
44.
44. Dr. Furr, in addition to adjustments to the physician fee schedule, what are some ways that Congress can better support physicians to help alleviate burnout?
Well, there's a lot with the quality measures. There is one thing that we really want to propose, that there needs to be a standard for quality measures. Every plan tends to come up with their own different quality measures. So you jump through all these different hoops trying to find out what the quality measure is for this plan. Some of the quality measures are automatically reported, but some of them we have to manually report. Sometimes you don't even know whether they get the information or not. So one plan tells me that they get the billed data from labs so that they know that it did an A1C and that the diabetic is controlled. I recently found out another major plan doesn't look at the lab data, so the only way they can find that out is I have to manually report it. So if they're going to require that, a lot of that needs to be done manually. But also with that, with a lot of the quality things, we're held accountable for things that we don't have any control of. I can offer a patient a flu vaccine, but I can't make them take it. I can, but I'll be guilty of battery. But I'm not given credit for offering that. I can put a code in and say I offered this vaccine and a patient refused it, or their meaningful other refused it, but it doesn't help me any with my quality. So one of the things that riles physician more than anything else is being held accountable for things we can't control.
Got it. Well, Dr. Furr, I understand that physicians face administrative burden when working with patients with complex or chronic conditions such as Alzheimer's disease. Now, these patients usually need access to timely care from a variety of physicians and specialties. You've mentioned that implementation of the G2211 code would reduce physician burden and allow for better care for these patients. How would implementation of the code impact overall care for patients like those with Alzheimer's?
I think the thing is we talk a lot about it for being primary care, but we're talking about people with chronic problems. So primary care, family physicians are not the only ones that would benefit. A nephrologist who takes care of his renal dialysis patients and takes care of them chronically could also use this code. An endocrinologist who takes care of diabetes on a long-term basis could use this code. And a neurologist who takes care of a patient with Parkinson's or dementia could also use this code. The most important thing about this code, it covers a lot of different areas, but what we're trying to do is take care of our sickest patients with the chronic problems and make sure physicians can afford to do that. I think the most important thing for us is primary care. We're able to take care of a lot of these problems, and then the specialists tell me they're overwhelmed because they're getting too many patients with minor problems. The neurologist is seeing too many basic things that could be taken care of in the primary care setting, but there's not enough primary care physician. So we could help some of our specialists by having more primary care physicians to take care of those problems up front.
Thank you. Dr. Fiedler, I want to talk about alternative payment model design in underserved communities. My district is a majority minority district, and our communities typically experience increased barriers to access quality health care. Doctor, we've heard a lot of positives about alternative payment models today. However, I'm concerned that these payments models have the potential to exacerbate health disparities, especially for underserved communities and communities of color, if not designed with these communities in mind. Could alternative payment models be designed in a way that recognize physicians working in underserved communities?
Yeah, so there have been proposals, and the Center for Medicare and Medicaid Innovation is currently testing the ACO REACH model, which takes an approach in this vein where the spending benchmarks set under the model are set higher in areas with large numbers of traditionally underserved beneficiaries. And the goal being to, by providing a more generous payment environment, to encourage greater investment in care for these beneficiaries. Those types of projects, I think, are still in the early stages, so it remains to be seen how successful they'll be in achieving those goals, but that is one strategy that's currently being tested.
Great, thank you. My time is expired. I yield back.
Gentlelady yields back. The chair now recognizes Dr. Miller Meeks for 5 minutes for questions.
Thank you, Mr. Chair. I think all of our panelists are here today. So I'm a former nurse, current physician, currently licensed, also 24-year military vet. I also practiced most recently in a community of 25,000 people. And I traveled 30 miles away to another community of 10,000 people to deliver care, in addition to making home visits, in addition to going and picking up people and driving them to my main office, in addition to driving them up to the University of Iowa so that they could get access to care. I've done academic medicine, small single specialty private practice. I've done military medicine, and I've been employed by a hospital physician. Which is why I was very proud to co-sponsor HR 2474, the Strengthening Medicare for Patients and Providers Act. And Dr. Furr, as you mentioned, this legislation would provide annual inflationary updates, and Dr. Pat, you also mentioned it, based on the Medicare Economic Index to physicians who support patients through Medicare Part B. I feel very strongly about this legislation, exactly for the reasons you've said. And so I'm just going to ask a very simple question. Does your organization support this legislation, and how could family physicians benefit from an annual inflationary update?
I don't know any physician organization that does not support that.
Thank you. And I would have questions for all of you, believe me. Dr. Fielder, you stated that healthcare providers incur substantial cost to interact with insurers, likely totaling hundreds of billions of dollars per year, costs that are ultimately borne in large part by consumers and taxpayers. And I will say that I have done pre-authorization, step therapy, just about everything that I can to reduce the burden on physicians. How do you think physicians' responsibility to negotiate contracts, collect information about patients' insurance coverage, and battle insurers on prior authorization impact quality and access to care? And do you believe the burden is higher for doctors in rural areas than those who operate independent practices?
Right. So when we think about, the ability of the payment system to encourage access to care, there's two sides of that equation. One side is the revenue side, but one side is the cost side of, what does it actually cost to deliver that care? And so, if we are imposing more on administrative costs, whether it be quality reporting or prior auth or other things, that means the payment rates are going to need to be higher to achieve the same level of access. In terms of what we might, what we might do about that, I think there are, particularly in the context of Medicare, I think particularly the merit-based incentive payment system is a clear place to look. We are imposing very substantial costs, thousands of dollars, as Mr. Albanese said, per physician per year to comply with this program. And there's very little evidence, unfortunately, that it's having the intended effect of improving the quality or efficiency of care.
Well, thank you for leading me to my next question, Dr. Albanese. As you pointed out in your testimony, alternate payment models have not lived up to our expectations. Furthermore, APMs have been largely focused on primary care and provided little opportunity for meaningful specialist participation. Clinical data registries drive healthcare improvements by providing prompt feedback on quality performance and appropriate use metrics, including patient outcomes. They can help physicians monitor and manage patient populations, facilitating early interventions and preventive care, which can lead to more successful disease management and less expensive care. Incentivizing participation in this proactive quality patient improvement and feedback tool was a congressional priority when it was originally enacted in MACRA. Many specialties and subspecialties believe that as implemented by CMS, qualified clinical data registries are not being recognized to their fullest potential and are only being used as an option for reporting MIPS measures to CMS. And I truly wish CMS had stayed here for all of your testimony and answers to questions. Do you believe that CMS has done enough to fulfill congressional intent when it comes to the role of clinical data registries in improving healthcare?
So I would certainly agree that access to APMs and the APM bonus by extension has been uneven among different specialties in different geographic areas. With regards to MIPS, MIPS as well as many of the other quality programs across Medicare are very siloed and don't tend to take a comprehensive view of quality improvement. And the incremental steps that CMS has tried to announce in this space have been slow in terms of yielding progress. So I certainly think it's important to try and have more data availability that allows meaningful measures for patients to compare quality between doctors and providers without simply having government officials decide what their priorities are going to be at the expense of patients.
Thank you. And then Dr. Pat, really quickly, do you think Congress overpaying entities through the 340B program will contribute to the amount that Medicare beneficiaries will spend on premiums?
I do. I think the natural consequence of the $53.7 billion program last year being a reduction in costs is, while we think of it as a burden to manufacturers, if manufacturers are selling 30-ish% of their drugs at a 50% discount, that ultimately that leads to an increase in drug prices, which is a burden borne on the backs of American dollars.
Thank you.